As you note, my name is Fergus Cumiskey. I'm the Managing Director of Contact. We're a charity with about 35 years' experience of working in the counselling and psychotherapy field in Northern Ireland, and we've focused in the last 15 years in the impact of the political conflict and the impact of aggression-related trauma. As a result of that work, we were the initial founder of the Independent Schools Counselling Service across all 230 post-primary schools in the north, and we pitched for and were awarded the Regional Lifeline Crisis Response Counselling and Assessment Service as a core strand of the suicide prevention strategy for Northern Ireland. So the business I run, third sector as it is, absorbs 50% of the Protect Life suicide prevention budget. I've provided the Human Rights Commission inquiry into emergency healthcare with our Safer Places paper, and I really don't want to rehash that in these 5 minutes, but I'm quite happy to answer questions on it because I know you've had an opportunity to reflect upon it. Just a number of things I want to say in the first instance in this 5-minute opportunity is that the death rate at the beginning of the political conflict was in and around the 300 mark per year in the worst of those years. So the trauma impact, the trauma sequel for Northern Ireland has been researched in many studies to have had a tremendous impact on long-term post-traumatic stress for the general population, but particularly for the population of men and women and children who were reared in that era in the most socioeconomically disadvantaged areas that took the greatest hit from the death rate of the conflict. That having been said, we now have more than 20 years post the initial ceasefire, a death rate by suicide in Northern Ireland that is coterminous with the worst of the death rate during the political conflict. Now, it's, at one level, that's a marvellous thing that we have sufficiently sophisticated recording mechanisms to be able to indicate our death rate as towards 17 per 100,000, considerably higher than anywhere else on these islands, and third or fourth in all of Europe in terms of the rates of suicide death. We have only begun to access proper figures in relation to the death rate and the lead up to a suicide death. And the field really, the lay field, the general public are drenched really in some very negative myth and stereotypes about suicide and what causes suicide, what the lead up to a suicide death means, about the nature of suicide death itself. And if the general population have some of those myths deeply imbued, then I would argue that the clinical population is bound to have a somewhat similar appreciation or lack thereof of what suicide is and what constitutes it, and therefore how to address it. And I say this advisedly because I lead an organisation that employs 200 clinicians that are involved in crisis intervention work, and we're dealing with post-trauma every day of the week. Now, while the NICE guidelines for the UK indicate quite clearly that there should be routine screening at A&E for aggression-related trauma such as domestic violence and childhood sexual violence, this is not the case. We still have yet to have primary healthcare or A&E routine screening in the appropriate circumstances for these psychosocial trauma creators. And as a result, we're very limited in terms of the sorts of questioning and the sorts of support, the sort of assessment we provide for people who self-harm and attempt suicide. One of the most powerful myths that we come across in our work, and we meet it when we're interviewing candidates for work with us who've had a rigorous clinical training, that people who wish to die by suicide would be dead already if they really wanted to. That's a deeply imbued risk. That's a deeply imbued myth in the clinical community as much as it is in the lay community. And people who self-harm never go on to die by suicide. Another very deep myth in the clinical and the lay community. Actually, my proposal to this inquiry is that we have to find a way to legislate to address this matter. 25 years ago, people would not have believed that we would have had routine and excellent training for child protection and vulnerable adult protection in terms of safeguarding. And that now is de rigueur and has been in place since about 95. We've had excellent legislation and very good practice in this part of the world in relation to these two matters. At basic assessment point, we're still not routinely screening for the sorts of trauma that occurs when there have been safeguarding breaches. But I believe very strongly that we should have a legislative stance that addresses the suicide prevention strategy and ensures that pre-clinical qualification, there's excellent training for assessment and intervention, not only for clinicians working in emergency healthcare, but for primary and secondary healthcare clinicians per se, and that there's across the course of the continuing professional development for all clinicians, renewal and update to those skills. That's on the inside of the gate. On the outside of the gate, we have assist and safe talk training, which are really excellent means of supporting lay people and those who are working very closely, professionals who are working very closely with people who may come into crisis from time to time, to be able to refer into services. But once you get through that gate, in study after study in the US, and it's the only place we're aware of where these studies have taken place, in at least 6 states, there have been workforce preparedness studies that have addressed primary and secondary healthcare. And less than one-third...
You're in your last minute, so...
Of course. Less than one-third of the clinician respondents to those surveys have said that they feel confident about how to assess and how to intervene when there's been self-harm or suicidal ideation. Now, we believe that that's bound to arc into our clinical contexts here. And I believe that the surveys need to take place, and that in turn will inform what I would hope for a legislative base to train for effective assessment and intervention, not just in emergency healthcare, but throughout primary and secondary and tertiary healthcare. So, introductory comments complete.
Okay. Fergus, thank you. My colleague Marion will pick up on the direct experience you have in the emergency department. I want to start by just looking at the issue of involvement in service planning, particularly in direct service provision on the ground and through the trusts and elsewhere. What I suppose I'm interested in, you've talked about a legislative option for dealing with some of these issues, and there are some, for example, who might argue that actually you need to embed practice and everything else, that legislation would be a rather top-down approach to this. So what I suppose I'm interested in is how much Contact NI is involved in service planning, in providing feedback. So, for example, the 10,000 Voices initiative, which we've heard a considerable number of witnesses give evidence that that's one of their key mechanisms for listening to patients and the public's feedback. Not the only one, but a key one. So what involvement, if any, have you had around, and the people that you work with had around 10,000 Voices? And are there other mechanisms within which you can access through the health service for the particular needs of the people you're working with, and specifically around emergency department feedback? So,
okay. In relation to the voice of service users and peer advocacy, really, within healthcare provision, we've been slow to the table, largely because the sector here has been slow to the table. But in the last 3 years, we have recruited 3 service user advocates for our business to begin to inform at a strategic level and at a policy and practice level exactly how we should organise services for the incoming era. That having been said, there is a real risk of lip service, paying lip service to peer involvement. And we're completely committed to train and support the development of peer advocates to take up staffed positions within our organisation, and also to take on board positions within our organisation to influence the shape of things to come. And we have plans for that over the next 18 months. In relation to the 10,000 Voices initiative, we've had no involvement with it whatever. But we've had 40,000 people who've used the Lifeline service, who've got individual anonymised identifiers. And since September last year, every single counselling session that we've provided in terms of wraparound, basically how the service operates is either a third-party referrer refers somebody with their permission into the service, or a member of the public can call the service. About 70% of the people who use the service have heard of us and been referred to us, and been signposted towards the Lifeline service by healthcare professionals. So we're a very closely bridged service to healthcare. The beauty of our service is that it's anonymous, it's free at the point of contact, and it operates as a gatekeeper come access point through the labyrinth that it sometimes is to access effective support. And we will engage with and build relationships with and case study with other providers to ensure that the person who makes contact with us at a moment of crisis or shortly thereafter gets access to the right kind of support. And every single counselling session that we provide direct wraparound face-to-face counselling, up to 6 sessions, and a little bit more for those who really need it. For urgent interventions. Emergency interventions go directly to statutory provision. Routine interventions go directly to the community or to other statutory provision. We're in the urgent care business, the urgent intervention with crisis. And every one of those 3,000 people since September last year have had individual outcome evaluations of their experience of the service.
Sure. What I'm trying to get, I think, from you is, I'm hearing very clearly that there's a very good engagement between the healthcare professionals and Contact and I. What I suppose I'm interested in is the experience you glean from the work that you do, feeding that back into the system, say, for example, an emergency department. Do you do that? Is that because you've never been invited to do it? Is it because never considered doing it, or there are not the mechanisms? I'm interested in the user involvement and how, in your case, a very effective NGO actually has its voice heard within, in this case, emergency department provision. Yeah. And if it's not being heard, have you any thoughts about how you can make it heard?
We take our advocacy and our citizenship and our third sector NGO status very seriously, but we're also in the double bind of being a service provider by service level agreement, and we compete for those service level agreements with the state. So at some level, to bite hard, it's the hand that feeds us to some extent. There's a real risk there. But in relation to the quality of the dialogue between our service and the governance provision there is for our service, we're governed by the health service. We're governed by the Public Health Agency, and the chair of the governance body for the Lifeline service is a senior clinician within a psychiatrist with responsibility for personality disorder for all of Northern Ireland for the Lifeline service. So we have an immediate access route at our governance level to give feedback on the quality assurance and monitoring of our service and the quality of our engagement with other services who refer to us and we refer out to at a governance level with the Public Health Agency. And all of the trusts are represented there, including the ambulance service. Now, what's missing from that, we believe, is other components of civic society that are critical, we believe. For instance, justice aren't there, and the police are a very important referral agent to us, and they're a very important intervener on our behalf when somebody's in crisis and they call our service and they need an immediate first responder. So we believe justice needs to be at that table. We also believe that education needs to be at that table because young people access our service a lot and confidentially. And we used to be of the opinion that, and many clinicians still are, that with the Gillick principles and the Fraser judgment, why would you engage with families or parents if a young person makes contact with the service? Actually, we're at a point now whereby, for the last number of years, it's why wouldn't you make contact with and engage with parents if there's the possibility of self-harm or suicidal ideation? So that has shifted very significantly. If we're working with a young person who's impacted or an adult who's been impacted by trauma, we need to really access and lobby for access to their immediate supports, their family, their loved ones, their community, including their GP, and immediate contact with their GP. So we have excellent bridging and linking relationships with, quite informally, with GPs, with social services, with emergency departments. However, we raised it in 2009 and have been militating ever since for rigorous memoranda of understanding with all branches of statutory healthcare. And yet we have not clinched the deal on those memoranda of understanding. We're really very close to it, and still there is some reticence in the system for that to occur. And we think it's about language and silo and authority and the invasiveness of the media and so forth. And actually we feel that transparency and openness and a plain-spoken engagement across services is absolutely critical, particularly at crisis point. So we have some frustration with this. In as many cases as we have complete cooperation without permissions either side, certainly with the client or the patient's permission, but not from statutory healthcare. But we have that locally. We have it informally. For everyone that we have that kind of cooperation, we have those who may refuse because they haven't got the statutory backup, they haven't got the governance, and they haven't got the regulatory backup to engage effectively with their service, or us with them for that matter. It's a tremendous frustration, and we believe in no small measure it's a wedge against better crisis services for people in this part of the world.
Okay. That neatly leads me on, I think, to Marion's, your questions.
Right.
Good afternoon, Fergus. I'm just wondering, in terms of emergency care departments and how they deal with children and young people, do you have any particular comments to make, and more particularly about children and young people who have mental health needs?
We find from feedback, direct feedback, it's anecdotal, we haven't run any research study on it. However, it's very strong. It comes through in many, many cases in working with parents and with adolescents in particular. Not very young kids, but adolescents and young adults. If someone is actively suicidal, their calendar age is not so significant. It's very significant when they're very young. It's not so significant, I'm talking about across the age course of 17 through to 25. We tend to regard young people as under 25. We take a youth and community work perspective towards it as opposed to strictly healthcare perspective towards it. And there's something of a timidness still around the preparedness of professionals across the board to speak directly with parents, guardians, and safety contacts, as we refer to them in our service, about the suicidal plans, the self-harming behaviour, and the state of crisis that a young person may be in. And these things are ephemeral, they pass quite quickly in some instances, and in many instances they remain for quite a long time episodically. And we feel that reticence is, again, a fairly strong pressure towards, it's a risk factor really in terms of suicide death. And really we have things to do around clinician education, and that's why I moved towards the legislative imprimatur. I don't think we'll change this culture without legislation. I think we have to have the good practice, we have to practice exemplars, we have to have excellent evaluation. Legislation will never come about without creating a context within which it fits, otherwise it'll sit in the statute book and never be implemented. We feel that there's a critical need for much better formulation really at crisis point about when and how to engage with safe enough adults who are involved in the care and support of young people when the needs of a young person comes to the attention of a clinician of any kind. And I include counsellors and psychotherapists as much as A&E department nurses and psychiatric staff and so forth.
When young people are going to any departments, either threatening self-harm or having self-harmed, have you any indication of how they generally feel received by the hospitals? Or?
We have. My Safer Places paper indicates this, and it's about 2 years old right now, but the feedback we've had in the interim is still very strongly in the direction of a sense of disdain and distance, and people arrive to A&E departments usually with a sense of shame and humiliation themselves if they've self-harmed, and with very paradoxical and conflicted feelings about themselves. And they often weigh up in A&E either with the support of a loved one or a friend or on their Todd, but a tad intoxicated, because that disinhibition enables their step forward. And I really want to say this, that as opposed to some of the commentary that's been made in the press and the political commentary of late around charging people, a fee who weigh in to A&E departments intoxicated, we'd be very concerned about this, particularly amongst young men. It's one of those opportunities where we will meet and see young males and young women who have harmed themselves or who have taken a substance. And because they're slightly disinhibited, they will show up for support in ways that they would not show up in daylight, would not show up in sobriety. So it's an opportunity for intervention that we otherwise would not get. So we're really passionately convinced that it's wrong-headed to begin to be thinking in a pejorative and a blaming and a labelling way for those who show up at our emergency services department intoxicated. There will of course be a few who will misbehave dreadfully, but most will sit very quietly, very meekly, and very much deepening their shame as they sober up if they're not treated and assessed the moment they arrive. And all too often that's not the case. They have to wait for very long periods, and just the sense of isolation, the sense of abandonment, the sense of burdensomeness, all of which are tremendously strong risk factors for death by suicide, increase in A&E departments. And sometimes A&E department is not the place for a young person or an adult who's experiencing suicidal ideation. It often is the place when they've self-harmed and they require a medical intervention, but they require it quickly. And they require a risk assessment, they require a psychosocial risk assessment, they require a circumstantial and, trying to indicate where the safety factors are in their lives, including, a safe person that they may go home with. And that de-escalation process and containment and stabilisation process from entry point to A&E to arrival back home, there is a massive gulf between A&E departments and home at this point. And we believe on the way to A&E and on the way from A&E, there is an absolute requirement for some really well-funded pilot or 2 or 3 across the country that looks at safer places at times of crisis in terms of the de-escalation, containment, and sometimes the crisis intervention that involves mediation and conflict resolution where there have been disputes to get people home. And this can be done, the best practice examples we know of, like Dial House and the Manchester experiment across the water, and many, many others in the US. People get home within 24 hours, but they're not trapped in the A&E department. They're not stuck with the revolving door of A&E services. And of course, that has its impact upon A&E staff. How could A&E staff be blamed in a way when they're bombarded at the weekends with lots of people who have shown up, who've self-harmed? Like anecdotal, again, reports from clinicians in A&E departments, it's 1 in 4. Every 1 in 4 has they're either self-harmed or they're threatening suicide or they're intoxicated, or all 3. So, we feel we just have not devised a structure yet whereby there's been an investment made in those kinds of pilots. And we feel that there is enough evidence base, both in the UK and in the US, to move pretty quickly towards this. And we've been militating for it for quite a number of years at this point. And it's something of a scandal that safer places at crisis times have not been developed as yet. There are governance concerns in relation to them, for sure. But I think with the right kind of interagency commitment and leadership around it, those steps can be taken. And really, they're critically important when working with the kind of adolescent dispute that can result in suicidal acting out really quite quickly. But one of the many myths around suicidal behaviour in the young is that it's impulsive. Young people are by far the most impulsive. It's the most impulsive age term across the life cycle. However, the death rate amongst young people by suicide is very, very low in comparison, say, to the over 60s, in comparison, say, to middle-aged men. But it captures a lot of the media attention. Actually, when we speak to young people who've been thinking suicidally or have self-harmed, they've been mulling this over and drenched in thoughts about it for months, if not years, before their first episode of self-harm. And what we also know about self-harm is that it's the greatest predictor of a death by suicide across the rest of the life cycle. Now, again, one of the phenomenal discoveries we've found from recent studies on self-harm and the self-harm register is that young people under 25, the World Health Organization have backed this figure that those in the teens and early 20s age category, it takes up to 200 suicide attempts for a suicide death to occur in that age cohort. Now, while that's a bewildering statistic, it's 200 opportunities to intervene and intervene effectively. And if we intervene in a ham-fisted way, when young people show up on our shores, so to speak, particularly in A&E departments, and feel as though they've been treated either prejudicially or stereotypically or in ways that are fatalistic and myth-driven, that just supports them to feel even more shamed. And it's also a myth to suggest that people who self-harm or are suicidal understand how and why they're in this position. They often don't. So the dialogue needs to be a robust one that can contain the most difficult of circumstances between clinician and the person who's in trouble, whatever age they are, and their loved ones. I mark that up really very strongly, their loved ones and their GP, because these are the people who are going to be working and living and engaging with them long after a visit to the emergency department. And we find that, again, another paradox, many end up going to the A&E department sequentially and lots of times in the middle of the night, not for somewhere to hang out, but because in their despair there is nowhere else that they can be treated or dealt with or engaged with. And our access rates into hospital beds have got very high in terms of the eligibility criteria, and rightly so, because psychiatric hospital is a very dangerous place for somebody suicidal to be. But the step-down and stepped care model of supporting people to get back home and to get back home safely and to get the sort of support they require once they're home, we're not there yet. And we believe sincerely that Safer Places is one of the models to get us to that point.
Thanks a lot, Fergus.
Oh. Thanks, Fergus. your organisation is a provider.
We are.
And so you have a service agreement with
the Public Health Agency.
Public Health Agency. Would you comment briefly on how that works? I'm just trying to get a sense of, in practical terms, real life terms, rather than just in the books, how that works. Could you briefly, time is short, I think we're already over time, so just briefly, could you comment on how that works and the negotiations for a new agreement, how that happens, and are you looking for, would you like the Public Health Agency to behave in a somewhat different way in those negotiations, apart from giving you more money?
Well, actually, that's not one of the things we're asking the Public Health Agency for.
So tell me, please.
We're very pleased that the last 5 years we've seen a ring fence and protection of the budget for mental health, and particularly for our work in suicide prevention. The Public Health Agency are well aware of how I'd like them to alter the way they work with us. You know, it's a little arm's length. It's very numbers oriented. It's a tad performance indicators and targets driven. And we're a strange fish because no service like ours exists on these islands. So for peer review, say for instance, when next we're up for a clinical review, and that's coming fairly fast, we've had one very recently, and we have another clinical review coming up fairly soon. We think that there should be a peer review component to that. That's not just service users, but other service providers who are delivering a somewhat similar service, be it from the States or elsewhere. So we're unique on these islands, and that leaves us a little bit outside the game, sometimes a little bit ahead of the game, sometimes a little bit behind the game. We think that there needs to be a more robust leadership approach taken with the health trusts and with the Health and Social Care Board in relation to driving through the memorandum of understanding for cooperation between our service and theirs and all other statutorily funded services at crisis point. That's an absolute given. It has turned up in dozens of serious adverse incident reviews as a recommendation in the aftermath of a death by suicide. And there's been very little progress on it. We're at the point where we have the blueprint in place and it needs signed off, and that needs driven through. We really very much welcome the Francis report and its implications in the UK. However, for that to be digested and internalised in healthcare systems is going to take time and tremendously courageous leadership. And we would implore that leadership steps forth in the Public Health Agency, the Health and Social Care Board and the trusts, and uses the funding crisis that we're facing as opportunities for root and branch culture change, not so much structure change, but culture and climate change, that says categorically, we're here with you at this moment in crisis. We're not blaming you for your crisis. We want to understand what it means, and we want to see you through to the other side of it and ensure that it doesn't recur for you. We're about the business of recovery as well as about treatment. And we're about the business of providing services at times that fit the need of the most in-need client as opposed to the institution that delivers the service. And that includes our own service. We're a 24/7 service, and we have to find our way to be flexible and engaging with complaints and with feedback that we receive. And we also believe that just like our service, now we're rather different from most in that every single, I was trying to say to Les earlier before he wound me up, the point I was trying to make was that we have client outcomes evaluation on every single counselling session that we have. We're not going to change the climate or the culture of primary or emergency healthcare until every patient is asked to engage with, in whatever way they can manage it, an outcome evaluation of how they were treated, what they felt was coming next, and were they treated humanely and courteously, and did they get what they needed at the time that made a difference of some sort in terms of the support for their understanding of the state that they're in and for the system's understanding of the state that they're in, rather than in some way be enveloped and talked down to and treated with contempt. We hear that all too often.
Thank you very much.
Fergus, thank you. We've said to all witnesses that we are, and we have considerable written evidence from you already, but if there is anything that you want to add to what you've said today, or if there's anything you think we've missed, we're more than happy to take additional written submissions from you. And before I thank you, is there anything finally you'd like to say before?
Yeah, I'd like to say this. I may have sounded a bit critical of statutory colleagues, but I'm here in a fancy suit. I may not be wearing a tie, but middle class, intellectual, well paid, and so forth. And I stood at a conference at the back of the hall, a conference with 1,000 people out of the States about 4 years ago. And a young woman stepped up to a mic just like this, and she was really very slight, and she had a very strong voice. And she said, 6 weeks ago, I had my most serious suicide attempt, and I heard this conference was taking place. It was the American Association for Suicidology, and I thought maybe this was a good place to be. I felt, and I was on one side of the split. The 1,000 attendees at the conference split in two directions. One took a sharp intake of breath and said, "Not yet, my lord." And the other half thought this was the most exciting and engaging thing they'd heard in years. Now, we have since moved a huge distance to include and involve the voice of service users. And it cannot be, we cannot afford for it to be an exercise in ticking boxes. It has to be about culture change and deep-seated culture change. And when we ask the question, the people we need to be asking the question about what shape should services be in for those who are in crisis, both in A&E and crisis intervention, suicide prevention services, the people we need to be asking are attempt survivors, self-harmers, and people who are in crisis and emerging from it, and their families. They're the people we need to be engaging with. They're the people who need to have the leadership voice. And the likes of me step right back.
Okay, thank you. Can I thank you? That's been really helpful to us. And thank you for the material that you've sent in as well. It's been really useful. Fergus, thank you.
Thank you very much for the opportunity.